Why do we have this chronic disease epidemic, rising rates of autism, cancer, and autoimmune disease? What's going on?
They would bonus you extra for doing additional surgeries.
Yeah.
Do they educate people on how to eat properly?
No. Look, we've poisoned the food supply, seed oils, pesticides, toxins, heavy metals. We have the most medicated generation in the history of the world.
But how are Americans not aware and up in arms over this?
The system is bankrupting the country. Right now, we're living in a new era of greed in healthcare.
Dr. Marty, thank God for doctors like you. There are a few of you who are not sheep.
Thank you.
Despite what most medical associations are hoping, there are doctors who are starting to speak up for us as patients and are willing to reveal the truth. And I've actually brought a few doctors, medical doctors, on my show because I think that you all deserve the platform and we all deserve to hear from you what is happening in this medical sick care industry. And so this is going to be another fascinating and informative conversation. So thanks for being here.
Thanks, Marissa. Great to be with you.
Let's just start with how did you get into this? I know how you got into medical school, but how did you become not sheep?
Well, I think naturally any human being is going to react when you see something that doesn't look right and have an instinct to ask a big question. And I think everyone starts off like that in medical school, and then they beat it out of you and turn you into kind of a robotic personality where you just develop a reflex to administer these thousands of medications you have to memorize. But I remember as a kid going to the mall. My mom would drive me to the mall about 15 minutes away. And once I saw this big plume of smoke that came out of the ground, and I said, "Mom, what's the smoke coming out of the ground?" And she said, "Oh, that's the Centralia mine fire. It's been burning forever, and it's going to burn hundreds of years, and it's the coal that's in there that's burning." And I thought, I guess it's kind of weird. I was a young kid, but okay, thanks, Mom. Like, I guess everyone grows up near a burning mine fire. And my dad is a hematologist who practiced his whole career in that area, blood cancers and leukemia, lymphoma. And he had observed a rare type of leukemia in very high numbers in that area. Well, obviously, he believed there was a correlation. And I assumed, well, somebody must be on top of this. Somebody must be looking into it. Somebody must be asking this big question. And nothing happened. And I would keep checking in with Dad. What's the situation? Are you still seeing a lot of these patients with this rare type of leukemia? I go to med school and I realize nobody is asking the big questions. I do all the training, collect all the badges, go through academics, get the degrees. I'm in practice specializing in pancreas medicine. And pancreas cancer has doubled in the last 2 decades. And at no point has anyone in our group or nationwide asked, why? Why is it going up? Why do we have this chronic disease epidemic? Why are half our nation's children sick? Why do we have rising rates of autism and cancer and autoimmune disease? What's going on? So that's a natural inquisition, I think. It's just you have to hold on to that curiosity and not let the medical establishment beat it out of you. Because it will. It will tell you to put your head down, do your job, diagnose and treat, medicate, operate, bill and code, and you're valued on your throughput, on your volume. But at some point, we have to zoom out and say, what are we doing? We have the most medicated generation in the history of the world. We've poisoned the food supply. People are not bad and non-compliant. Maybe we've given them the wrong information and they're exposed to things that are making them sick. And maybe the hard part of chronic disease is not telling people what to do, it's helping them do it. So you got to take a step back. And our medical system is so expensive. It's so, we have the most medicalized generation in the history of the world. With children, we assign mental health diagnoses very liberally. In some cases, it's the medicalization of ordinary life. Mm. And nobody is saying, hey, what's going on? We're creating this massive industry, but nobody's dealing with the root causes.
Well, Doctor, you're at Johns Hopkins, right? You're a surgeon there. And I have to assume that there's a lot of research going on at Johns Hopkins. So when you're saying nobody is asking the big questions, Well, where's all the money for the research going?
The research is by and large funded by the pharmaceutical industry, and they are looking at chemical pathways that you could block with a drug. And that is the basis of a lot of the research and even the mindset, the culture of medicine from early in medical school. You're kind of taught everything's a blood chemical reaction. Attention deficit disorder, it's a chemistry problem in the brain. Nowhere do we ask, well, maybe we're asking kids to sit firm and sedentary in a classroom for 7 hours a day. Maybe that's not natural. Okay. Maybe if a kid disagrees with an adult, it's not oppositional defiant disorder. I mean, the most bogus of all the diagnoses we have in medicine. If a kid just doesn't like them, disagrees, we have a diagnosis for that.
Right. If they have a hard day, that's PTSD and trauma, and then they have to be medicated for it.
Right. You have anxiety. Now for
Right.
no one's talking about communities or the human connection or the food supply or what's making them tired after lunch. So we've got to take a step back. And there's a group of doctors now that are saying, let's stop. Let's stop this rat race. We're on a hamster wheel to get a bigger bonus every year. I was told, hey, if you do more operations, we got a bigger bonus for you at the end of the year. And at a certain point, I was like, no, I'm not doing this anymore. I've always been interested in public health. I left medical school after my third year to enroll in public health school. And this is my passion, and this is really what I'm dedicating my career to.
Doctor, what you just said is so crazy. You just said that they would bonus you extra for doing additional surgeries.
Yeah.
So what if people didn't need their surgeries? I remember reading your first book. One thing I'll never forget was in your first book, you describe how some surgeries are done that are not even needed. And sometimes surgeries are done on parts of the body that didn't even have any sort of symptom
Nothing
or
wrong with
problem.
that,
It was just a mistake surgery, which I guess the mistakes hopefully can get corrected. But this incentive to operate extra is something that you experienced?
Oh, yeah. And most doctors do. And look, it may make sense for a radiologist reading films, but a surgeon or a primary care doctor, you need to spend time with people. You need to understand their lives and get deep. And we're on this treadmill of just do more volume, increase the throughput.
Why? Why do more
Because
surgeries on people that don't need surgeries?
the hospitals get paid more. Everyone's happy. So everyone is essentially doing their job by encouraging you to be more productive and then turn a blind eye to the appropriateness of care.
Yeah, well, we're not happy to have more surgeries on us.
I've joked around with my administrators once. I said, they came to me at the end of the month and they're like, this month you're a little below your monthly target for operations that you need to do. And I said, oh, okay, would you like me to start removing healthy organs that don't need surgery? Just tell me, be very clear what you'd like me to do. And look, I don't think we have bad people in medicine. We have good people working in a bad system. It's a system we inherited. And it's a crazy system that we've got to step back and stop saying, we need more money, we need more money. The system is bankrupting the country. It is the largest business in America. And what are we getting for it? Horrendous health outcomes, a surge in all of these diseases and cancers and childhood conditions. We've got to take a step back and look at the big picture.
In your book, The Price We Pay, there was something that I learned that when you go into the emergency room, you suggest that we should sign "did not read."
There's no reason anyone should sign a financial document in an emergency. Ever. Never do it. If you're forced to or you're told you need to sign this, you can sign in the signature line, "did not read," or "this is not a contract." Because by law, hospitals and doctors are required to take care of anybody in an emergent or urgent situation, regardless of their race or their ability to pay. And that is a law. So right now we're living in a new era of greed in healthcare, where we are watching price gouging and predatory billing with predatory contracts that patients are asked to sign when they come in for care. They're coming in earnest for help. They need help. And we are taking care of them and ruining their life financially in this predatory way. You should never sign your life, retirement, home, mortgage, savings away on a document without a price, ever. And so healthcare is engaged in this predatory billing because of this underlying greed. You don't need to sign it by law. There's a law called EMTALA. You can cite it if you're ever in an emergency situation.
Such an important topic from your earlier book about the contracts and people going bankrupt, and that is that you can actually negotiate with the hospital after the fact because we're coming in at a place of desperation, we're in pain, or we have a loved one in pain or possibly dying. You don't know what you're signing. You don't even know what they're going to charge you. I've been in situations like this before where I've gone into the emergency room and I just want to know, well, what would this procedure even cost? And the answer is always, we have no idea. We will let you know. The insurance will let you know, et cetera. It's just a crazy system where we don't know what this is going to cost us. And so you are saying that an individual can actually go and negotiate with the hospital after the fact, which is so important.
That's right. Little known fact, you can negotiate your bills. You got to get to the right person. I'll tell you, the staff and the people who are connected and powerful in a community, they know how to get to the right people and negotiate down these bills. But unfortunately, poor and minority communities are getting gouged by the system. So that's an important tool. People need to know you can negotiate bills before, during, and after the care. You can identify mistakes. About 30% of medical bills will have an error on it. And you need to be able to get to somebody who can help you with that because you wouldn't allow an airline to charge you after the flight without having a price on the websites. Can you imagine if United Airlines said, we can't give you a price for this flight. We don't know what it's going to cost. We don't know if the pilot's going to have to experience turbulence and what the price of fuel is going to be. And heck, you might consume a beverage. So we can't give you a price. Plane could crash and that would cost the airline millions and they might have to charge you millions. You would say that's a dysfunctional marketplace. And the fundamental problem in healthcare is that we have non-competitive markets. We have markets competing on dumb stuff, valet parking, NFL ads. We need competition based on price and quality, which includes the appropriateness of care. So my team at Johns Hopkins is developing appropriateness measures to evaluate the appropriateness of care. And we were able, after the book, The Price We Pay, to get the Trump administration to sign an executive order requiring hospitals to post prices for common shoppable services. And the secret discounts that the insurance companies have with the hospitals have to now be made public. And this is the first year we're going to see that take place.
Oh, wow. Okay. So I'm glad you bring me some good news because I was worried about this.
Good stuff
I was worried about it. I
happening.
was like, so, and the other thing that I noticed when I was with my mom in the hospital is that you can barely speak to the doctors anymore, partially because they're busy and partially because you have these risk managers that are basically creating a wedge between the patient and the doctors. I know that doctors are good people. I know you guys. Half of my friends are surgeons and doctors, good people who really want to help.
Yes.
The problem is you have all these lawyers and in-betweeners that are stopping us from communicating.
We've created tens of thousands of millionaires in healthcare who are not patient-facing. These are folks who sometimes are middlemen who are creating issues that they need to resolve. For example, why does a hospital have to have a set negotiated price with an insurance company? Each party hires armies of lawyers to negotiate that contract. Why do we have networks? You come into the clinic and they say, oh, where's your insurance card? You don't have insurance. Oh, my God. We need your insurance. I have to put it in the system. The shakedown for the insurance card, but the reception counter is one of the problems in healthcare. If we had honest and transparent prices, you wouldn't need these crazy networks. You wouldn't create the problem that you're there to solve with an insurance network. The insurance network is the arsonist and the firefighter. It is the savior for the problem it creates. You're out of the network. Oh, you need to be in the network and pay a regular fee. So if we had honest and transparent pricing, you could cut a lot of the middleman waste in the system and the kickbacks. The kickbacks are a major problem. We're not allowed to take them as doctors, but the middlemen people in healthcare are allowed to take health kickbacks. That needs to stop.
So do you think that a single-payer system would be better because then you remove the healthcare bloating in the middle, or is that going to cause us to have a worse situation because then it's all in the hands of the government?
The single-payer system is attractive because in the short term, you do cut out a lot of the waste. But over time, invariably, in every country in the world where it's been used, the governments cannot resist an across-the-board cut of that entire budget. And what you're left with 10 or 20 years down the road is a massively underfunded and even dilapidated system where it's no longer valued. The doctors are treated like civil servants. In the UK, they went on strike, and the government said, you can leave. It doesn't matter. And you see wait times go up and rationing of care. So there are two ways that we can address our current healthcare system. One is to just keep spending an unlimited amount of money on it. We're already spending 50% of federal spending on healthcare. You might say, wait a minute, Medicare is supposed to be Medicare and Medicaid through the FMAP program back to states, about 25%. How do you get 50%? Well, Social Security checks are being used for healthcare, co-pays, non-covered services, deductibles, coinsurance. The military has its own healthcare system and medical schools and insurance program. We have the VA system, and we pay for healthcare benefits for 9 million federal workers. So it's like half of the entire federal expenditure goes to healthcare today in its many hidden forms. We can either increase that further, throwing good money after bad into a broken system, or we can cut the waste and focus on getting people healthy instead of focusing on playing whack-a-mole on the back end of care.
Well, speaking of government overreach when it comes to the medical system, censorship has been another big issue. I mean, we've become so aware of it during COVID, but it seems like this has really extended beyond these lockdowns. How have you experienced censorship?
Well, we did the largest study of natural immunity in patients, drawing the blood of people who had COVID in the past and evaluating their antibody levels and duration. And we published it in our number one medical journal called JAMA, Journal of the American Medical Association. When I posted our study on natural immunity on the internet, it was taken down. LinkedIn pulled it. Other media outlets dethrottled it. This was a scientific study that ended up being the second or third most read study in all of JAMA, according to their own website. And so the way in which our medical leaders have done science is to crush dissent when a study shows them a result that they don't like. And so we saw them over and over again propagating false narratives. The greatest perpetrator of misinformation during the pandemic was the United States government, saying that natural immunity was not real, that vaccine boosters helped young, healthy people, that toddlers had to wear a mask for nearly 2 or 3 years, that schools had to be closed for a prolonged period of time, that Paxlovid worked in low-risk individuals. The data has caught up with public health officials, and they not only got it wrong, but they stuck to their guns when the data told them they were wrong.
And not only did they never apologize, but they doubled down on the censorship. We're still experiencing medical censorship.
Yeah. I've not heard a single apology, Marissa, from any public health official as if they didn't make a single mistake. I can tell you, taking care of patients, when you apologize immediately, as soon as you realize you're wrong, people can be very forgiving. But you've got to be honest with them. And instead, they've doubled down. They have, claimed that there were all these benefits. They've rewritten history. They've ignored the literature in the scientific study field that they don't like. So the censorship complex is still alive and well. Matter of fact, Jay Bhattacharya and several of us are going to be having a symposium to evaluate COVID policies at Stanford. My friend, Dr. Bhattacharya, organized this. President of Stanford is going to be attending and making remarks. Well, Peter Hotez and others out there are condemning it, saying that the president should boycott this and that this is terrible. They're spreading anti-science. There's tenured public health researchers from Oxford and the University of Chicago and UCSF and Johns Hopkins and Stanford. There's something about civil discourse right now where we are seeing a total intolerance by one political, and it's always in one direction. The censorship is always in one direction.
Weren't there a few doctors who actually sued the Biden-Harris administration for medical censorship, and then the AMA went ahead and filed an amicus brief in favor of more censorship? Yeah,
the Biden administration told Facebook and many social media companies, take down this post. here are specific people and here are specific posts that you should delete, dethrottle, do something with. And sometimes they were dropping a lot of curse words, angry, threatening these social media companies. Mark Zuckerberg's come out now saying he was repeatedly pressured to take down these posts, including of satire and humor. And this is the United States. You can make fun of anyone you want. When we have the government saying you cannot make fun of someone, now, I wasn't making fun of anyone that I know of on the internet, but we were trying to give a different point of view. And on school closures, on toddler masking, on vaccines for young people, on the mandate, we were correct. And the data has shown that. And here is an administration that defended to the Supreme Court that they should be able to censor physicians. The American Medical Association and a bunch of other medical groups, what I call the medical establishment, filed an amicus brief in support of the Biden administration censoring physicians on expressing their opinion. These are respected opinions. That's a scary place. When you bypass the experts at the FDA and fire our two nations' leading vaccine experts there in order to get a vaccine approved in a booster form for young, healthy people, then mandate it on young people, and then censor doctors who disagree, that is a very dangerous place in America.
How are Americans not aware and up in arms over this thing? The other thing is when you talk about the AMA and all the other acronyms for other medical associations, there must be thousands of them. So forgive me for not memorizing all of them. But I actually have lost respect for them. And so they all kind of commend each other and peer review one another and censor on behalf of one another. So you're a member of some of these groups, and I think some of them are considered really, really highly regarded. I mean, what is the one, the National Academy of Medicine, which you're involved in? And, I'm sure it's a great thing, but I have to say I'm really losing faith in some of these organizations where I read that in order to pass the annual membership with this group, you actually have to admit that you subscribe to environmentalism and you're not a climate change denier or something like that. What does climate change have anything to do with the National Academy of Medicine? And why are they asking you guys to pledge allegiance to that?
Well, I'm proud to be a member of the National Academy of Medicine, but I was surprised on the application when on the one-page application at the top was a box saying this candidate has a focus on climate change and health. So we have this sort of bandwagon thinking, and now I think it's health equity. And it's created a lot of posturing. I've seen people come through that say, in general, who say, I have dedicated my life to studying a lipid in the mitochondria, and I'm a champion for health equity. And so there's a lot of this posturing. And if you go to the medical conferences today, 25% to 50% of the research studies that are being presented are on health equity.
What is that?
They are describing that there are differences in health outcomes among people who are wealthy versus poor, or people from majority versus minority communities. Now, describing those differences is not interesting. We know those differences exist. What's interesting is reducing those health equity gaps. And you don't see discussions about that. You don't see research on that. Instead, what you do is you just see these descriptive studies to almost make us feel good like we're doing things. There are some universities that are doing a lot in health equity, having conferences and symposiums and grandstanding, but they don't accept Medicaid. They will not accept people if they don't pay the full bill in advance. And these are major institutions in America. So,
do they educate people on how to eat properly?
No. Look, the medical establishment is so busy with its billing and coding and throughput model and posturing that they're doing new operations. Like, I'm a surgeon. We have had a tour de force of procedures that we've pioneered, both at my hospital, Johns Hopkins, and among my friends. And at no point are we doing anything to prevent people from getting these conditions, even though 90% of diseases today are entirely preventable. So we've got to take a new look and talk about the big topics that no one's talking about. Seed oils, pesticides, the food supply, toxins, heavy metals, things that are where there's a good body of evidence to support, but we've basically cherry-picked the research to say we're only going to focus on these things, not the issues that actually pertain to our environmental exposures and food supply.
Is America's medical system just completely in decline? I mean, there must be some new technology, new exciting things going on. Is AI a good thing or is it necessarily a bad thing? Right? It's like one of those things where I guess it can do good and do bad. Do you have any good, exciting news?
I get this question a lot. Is AI going to transform your life as a surgeon? We don't need AI in healthcare. We just need We need basic intelligence. They're still asking me every morning when I walk into the operating room what glove size I wear. Dr. Makary, good to see you. Good morning. Are you a 7 or a 7.5? I'm a 7.5. Oh, okay, we'll go get that. We just need sometimes in healthcare.
Yeah.
Now, I do think there's a role for AI with pattern recognition. We've seen it with reading EKG results. We're going to see it more in radiology, maybe as a backup to physicians taking a look at it. We're going to see it with dermatologic conditions and photographic diagnoses. So there's going to be a role for AI, and that's good. But AI is not flying planes without a pilot. I think we're a long way from seeing AI single-handedly run the healthcare system.
In your new book, Blind Spot, you talk about some fraud when it comes to research that has been submitted around pharmaceuticals. Do you think that AI could become now a tool for additional fraud?
Sure. AI could be a tool to both detect fraud and create fraud that averts AI detection systems. How do you teach ethics to a group of doctors in training? How do you teach humility?
Are they even taught these things?
I'm not aware of it. And quite honestly, when I talk to my students about how do we start talking about the non-technical skills of being a doctor, not tying knots and sewing patients up. I'm talking about communication, listening to patients, having the humility to say, I don't know when that's the right answer. If they ask a question about something I'm not familiar with, I'll take a look. I'm happy to research it for you. I may know of somebody else. I'd be happy to talk to that person. Who's in charge sometimes? We've got to teach not just the technical skills, we got to teach the non-technical skills of teamwork and communication and bringing people together and focusing on a problem. Right now, we have this kind of hyper specialization where everybody's got a hammer and I'm going to do this, I'm going to do that, I'm going to do it. But so many things are connected. And if we would actually stop and find out what the underlying root causes are, you wouldn't need to be doing this stuff. We did a study in my research team at Johns Hopkins on unnecessary medical care, asking doctors nationwide in a survey, over 2,000 doctors, in your opinion, what % of medical care is unnecessary? The average answer, 21%. And they broke it down. Medications, diagnostic tests, 11% of procedures. But overall, it was 1 in 5 services in healthcare. Now, in any industry, if the people on the front lines of that industry tell you that 1 in 5 services are unnecessary, that's an industry in crisis. And everyone in healthcare is getting rich. Every single stakeholder, arguably with the exception of some rural hospitals. But the hospital association, the doctors, the insurance companies, the middlemen, the device, everyone is at a party making a lot of money except for one stakeholder, the American worker, the consumer of that system, who are funding this giant game on the backs of their jobs through a paycheck deduction. If you look at a paycheck, there are 2 places we steal money from the everyday American worker. One is their health insurance contribution, and the other is the Medicare excise tax. And because those numbers are so big, the United States is not competitive with countries overseas. Jobs are leaving the United States. We're creating this industry of doing things to our own people. Now, look, I love being a surgeon, and we do a lot of good in medicine, but we do a lot of good in the emergent acute setting. When you start talking about chronic diseases, we're losing. We're going backwards. It's getting more expensive, and the public is getting sicker. We've got to stop and take a new approach. We've had terrible leadership in medicine. They've done a terrible thing to doctors. They've said, put your head down and just do this job and you'll be rewarded. And we haven't given doctors the time or resources to actually look at what's bringing people to care and how can we prevent a lot of these problems.
Well, and then what they told us, the patients and the American citizens, is that we should just believe all experts. And so they say to us, well, just sit back and believe the experts and we'll do the work for you. And I think that one of the things that we've learned now is that we need to put in the work ourselves. We need to understand what is being prescribed to us, what is being pushed onto our children. And you have outlined in your book a bunch of examples of, I guess, medical faux pas that remain as unknown to the public. So in the effort of trying to educate the public, let's go through some of these medical faux pas and just a quick little game, I guess, just one by one, we can review them.
And on that point, Marissa, a bunch of us physicians have said, we're not going to just work in the walls of a hospital anymore. We're going to go to the public and we're going to educate them and tell them the real story about health and the latest scientific research. Because the road we're going on is not a good path. Maybe we need to treat more diabetes with cooking classes instead of just throwing insulin at people. Maybe we need to treat more high blood pressure by talking about sleep quality and stress management instead of just throwing antihypertensives first line after second line after third line at people. Maybe we need to talk about school lunch programs, not just putting every kid on Ozempic that's obese.
Or claiming that ketchup is a vegetable.
Right. There's two types of ketchup, one made for the United States and one made for overseas. And the one in the United States is basically poisoned with high fructose corn syrup. So these are the topics we've got to be talking about. Food is medicine, general body inflammation, and what drives health, not just sickness.
Well, what you're saying about the medical field, where we were expected to just believe the experts and just forfeit our responsibility essentially to these experts, is so similar to so many different industries in America in the world of education, right? Parents are now waking up and realizing that education is part of their responsibility too. They can't just give it to the Department of Education or the teachers' unions or whatever administrators to be responsible for educating their children. Everybody has to lean in those ways as well. And so I think that this is a moment where people are taking back some responsibility. And in order to do it, having doctors like you giving us a little bit of a roadmap of what to look at and what are some of the really well-researched medical innovations, both the faux pas and the successes, is so helpful. So one of the things you write about in your book, and probably one of the most important for people around my age, women around my age, is hormone replacement therapy. So we were told that hormone replacement therapy could lead to cancer, and therefore many of our doctors have really talked us out of going on those medications. So what's your comment on HRT?
First of all, this topic represents one of the biggest screw-ups of modern medicine, arguably maybe with the exception of a bunch of scientists in Wuhan messing with a bat coronavirus, creating a pandemic that killed 20 million people. We have a medication that mimics a body's natural hormone, estrogen, estradiol, and progesterone. And when women stop producing it or reduce their production at the time of what we call menopause, if you replace that with taking what we call hormone replacement therapy, the results are dramatic. There's probably no medication in the modern era, with the exception of antibiotics, that has improved or could improve the outcomes of a population more than taking hormone replacement therapy after menopause in women. Women live about 3.5 years longer. They feel better. It alleviates the hot flashes and brain fog and mood swings and night sweats and other symptoms that women may experience at the time of menopause, which can last for 8 or 10 years. Women have half the rate of heart attacks and fatal heart attacks. That's the number one cause of death in women. If a woman is experiencing cognitive decline, reduces cognitive decline by 50 to 60%. In one study, reduced Alzheimer's by 35%. A woman has stronger bones. It reduces osteoporosis. You can take all the vitamin D and calcium in the world, but unless you have estradiol in your system, it's not going to help. So if a woman starts hormone therapy within 10 years of menopause, if they fall or in a car accident later in life, they're far less likely to need an operation or break a bone. and have the immobility and cascade of events.
So that's what, estrogen and progesterone?
Estrogen, and then if a woman still has a uterus, they recommend progesterone in addition. So here's an amazing intervention in modern medicine. And the reason why most women are not told about this, or they're told not to take it, is because 22 years ago, a doctor at the NIH announced in a press conference that he had just completed a major study and found that taking hormone replacement therapy increases the rate of breast cancer. He didn't release the data. Later on, when the data was published, many of us looked closely at this data and said, hey, wait a minute, there's no statistically significant increase in breast cancer. I found him in doing the research for Blind Spots, interviewed him in retirement, and he acknowledged to me that there was no increase in the rate of breast cancer mortality. He had misrepresented his data. And immediately when he made that announcement 22 years ago, women flushed their hormone therapy down the toilet. And 50 million women have been denied the amazing benefits of hormone replacement therapy, all because of this dogma. And to this day, medical schools really don't teach about menopause because it's been assumed there's nothing you can do for it. This treatment causes breast cancer, even though it's not true. It was never been found to increase the rate of breast cancer mortality. So women who come in to see their doctor today with menopause, tragically, are more likely to be prescribed an antidepressant for their symptoms instead of replacing the body's natural estrogen.
Yeah, I wanted to bring that one up first because so many of the examples that we've been bringing up lately are, well, you shouldn't take these things because the pharmaceuticals are trying to sell these things to you, or there are, too many vaccines or too much antibiotic. But this happens to be one of the things where you say, this is a medical miracle. And yes, you should actually go and get these things.
Yeah, it shows the nuance and the importance of being scientifically precise.
Right.
And there's probably no medication that enables women to feel better and live longer with healthier outcomes across the spectrum of cognitive decline, heart disease outcomes, orthopedic outcomes than hormone replacement therapy. So if your doctor says it causes breast cancer and not going to prescribe it, keep looking for another doctor.
Right. Okay, so you mentioned ovarian cancer, which is another faux pas.
Yeah. So ovarian cancer, it turns out, does not come from the ovaries. This amazing discovery that the most common and lethal form of ovarian cancer actually comes from the fallopian tube. Mm-hmm. The cells then float onto the ovary. And we've been calling it ovarian cancer, but it's really from the fallopian tube. We should be calling it fallopian tube cancer. Now, no screening has ever worked for ovarian cancer. A big study just concluded in the UK. There's nothing we can really do to prevent ovarian cancer. But now we're recognizing when we were taking out millions of ovaries that were healthy and normal, with the idea that we were preventing ovarian cancer, we should have been removing the fallopian tubes.
Wait, who would take out their ovaries when they're still healthy? Is it because they tested for the BRCA gene? Is that why they would take them out?
That was one reason. But many women who were low risk would have their ovaries removed at the time of a hysterectomy or other abdominal or GYN procedure with the rationale, and this has been going on for 50 years, that we are preventing the 1 in 78 chance of you developing ovarian cancer in your future. That's the risk of it for every woman out there.
So if you don't want to have children anymore, the claim was you don't need your ovaries, so you might as well take it out so that you don't get cancer in there.
That's right. That was the rationale, especially in women after they went through menopause and the ovaries were not producing hormones anymore. So that was the rationale. And we're learning now, and we have a new protocol now that says leave healthy ovaries in place in low-risk women if you're taking out the uterus. You're not preventing ovarian cancer. That's at least our current thinking. But removing the fallopian tubes, which serve no function after having children, that may massively reduce that 1 in 78 chance of developing ovarian cancer. So when a woman comes in to have let's say I'm going to remove their gallbladder for gallstones, we're now offering at Johns Hopkins, if you're done having children, would you like us to have your fallopian tubes removed by one of our GYN doctors while I'm in there doing the procedure to reduce your 1 in 78 chance of ovarian cancer? And if a woman comes in and says, I'd like my tubes tied, our new answer at Johns Hopkins is we don't do that anymore. We remove the fallopian tubes to reduce your risk of ovarian cancer.
You talk about this piece in your book, but you haven't spoken so much about testosterone. So I'm just curious about the male side of the hormone therapy.
There are some parallels between hormone therapy in women and testosterone replacement in men who have low levels of testosterone, but it's nowhere near a true comparison because the benefits in women are overwhelming of hormone replacement therapy. Now, the dogma is correct. There's been a dogma that replacing testosterone can cause prostate cancer. That is also not supported in the literature. And there are some benefits for candidate individuals with low testosterone. They feel better. It's not as simple to just take a pill or wear a patch. But men do benefit from testosterone therapy. And it's unclear if there are cardiovascular benefits in addition to feeling good and losing weight.
Okay, back to women.
Yeah.
So you talk a lot in your book about C-sections, and you also talk about the delayed cord clamping, which the story you talk about, you wrote about from what you learned from India is just astonishing, and people will probably dive into the book and read it. But can you give us a quick synopsis of what should we know about C-sections and cord blood and VBACs?
When I was a med student, I was given the scissors in the delivery room, and I was told the second you see the umbilical cord, we're going to clamp it and you cut it. And the baby was born in this sort of chaos. And then it was like, there it is, Marty, cut it.
I remember it's like pumping, right?
Yeah, it's still pumping. And it's, what are we doing? Their baby was getting blood flow from the mother of stem cells and fetal hemoglobin, which binds oxygen very tightly, and antibodies and warm blood. Like it's warming the baby. It's a warm infusion into their circulation. We were cutting the cord so we could take the baby to a back table and try to warm the baby under a French fry light or whatever we're doing there. What were we doing? This is the medicalization of ordinary life. We now know there's good data to show that you should let the umbilical cord pulsate for a minute or two after the baby's born. It's called delayed cord clamping. Every woman that's going to deliver a baby should ask about it. And the baby should go back in the arms of the mother.
For how long should you delay the cord?
One study shows 90 seconds is better than 45 seconds. I say the doctors I respect in this field say, as long as the cord is still actively pulsating, 2 minutes is a good general time frame. But the baby should go back in the arms of the mother. By the way, they've done studies showing that the brain myelination is different in babies later in life.
Wow.
And when the mom is holding a baby, what we call skin-to-skin time or kangaroo care for hours, not like, here, you get 2 seconds and now we have to go medicalize the baby in the nursery, even though there's nothing wrong with the kid. There's something magical about the bonding that we have not fully described in medicine. We know the heart rate is more normal, the blood pressure is more normal. Neonatologist at Baylor, Scott and White and McKinney has found that they're less likely to go to the NICU and need a blood transfusion if you do delayed cord clamping and skin-to-skin time where the mom holds the baby as a natural incubator. And their blood sugars are more normal. And as a doctor, I thought, wait a minute, I'm very intellectually curious, especially in medicine. I don't get the blood sugar being more normal if the mom is holding the baby. And they said, the stress hormones are not spiking, and that influences your glucose. And I thought, yeah, that makes sense. They're not as stressed. And the microbiome, which is the lining of the GI tract of millions of different bacteria that live in harmony, that digest food. It's a central organ in health in a blind spot of modern medicine.
Yeah.
It trains the immune system. It produces serotonin involved in mood. The bacteria produce GLP-1, the active ingredient in Ozempic. And when a baby is breastfed, they have a more natural microbiome. So when there's skin-to-skin time, initially the baby's more likely to latch and breastfeed. A baby should not have antibiotics if they don't need it upon being born. That alters the microbiome. It carpet bombs the microbiome.
Are they giving antibiotics to babies?
They used to give them routinely for all premature babies.
Oh.
But the babies were not sick. They're just early. And now we're recognizing we did too much of that. Sadly, in C-section deliveries, they give the antibiotics before the C-sections. The antibiotics are already in their system. They smear this erythromycin cream in their eyes, even if the mom tests negative for the bacteria they're trying to treat. It's the over-medicalization of ordinary life. And so the babies are exposed to antibiotics. And a study found that 80 to 90% of babies by the time they're 2 years of old have already received a course of antibiotics. That is carpet bombing the microbiome. Now, antibiotics save lives and C-sections save lives. But when a baby is born through a vaginal delivery, they have their microbiome seeded by the bacteria in the birth canal. A baby has a sterile gut in utero. When they're born, that microbiome, that garden of bacteria, forms from the bacteria in the birth canal, from the breastfeeding, from skin contact, from grandparents kissing babies, and that's the normal colonization. But when you're born by C-section, a sterile baby is extracted from a sterile operative field. And what may colonize the microbiome are the bacteria that normally live in the hospital, which are not good bacteria. Study just came out in JAMA Surgery, one of our big journals, just this year. The rise in colon cancer that we've seen in young, healthy people under age 50 has been associated with a C-section delivery. And the microbiome alteration from antibiotics in the first few years of life was studied in this amazing study out of the Mayo Clinic that in 14,000 children, they compared kids who received an antibiotic in the first couple years of life versus those who did not. And in this very elegant match study, they matched the kids as best they can. Kids who received an antibiotic in the first few years of life had a 20% higher rate of obesity. Farmers had noticed this in animals for a long time. Give an antibiotic, the animal's fatter. A 32% higher rate of attention deficit disorder. A 21% higher rate of learning disabilities. By the way, all these conditions have been going up in the modern era of antibiotics and unnecessary C-sections. Again, antibiotics and C-sections save lives, but most are unnecessary. And a rise in asthma, 90% higher rate of asthma in the study, and nearly a 300% rise in celiac disease. So when people come in and say, hey, how could my little Billy have celiac? How did they get this? We've kind of, made stuff up or said we don't know. Here's a signal in the data. We've been altering their microbiome. And that is likely a driver of not just celiac, but many of these conditions.
So, doctor, I have 3 kids under the age of 11. So I am very much in this, right? I'm very close to it. And what goes through my mind when you describe the dangers of antibiotics and how we are basically TNTing their microbiome, I get that. I get that we don't want to overprescribe these kids. But what do you do if a child has an ear infection or has pink eye or the child is in agony, they are struggling, they're suffering, they're in pain, and you don't want them to go deaf?
Yeah.
So how do you find truly that balance? Because isn't that what it is all about? It's that balance.
It's a balance. And that's where clinical excellence is what we need in healthcare today. We have telemedicine visits where they're not even looking in the ear and they're prescribing antibiotics. We did that study at Johns Hopkins. You're far more likely to get an antibiotic in a telemedicine visit. You've got to have the clinical
or like the urgent
excellence.
cares. The urgent cares, they'll prescribe very quickly.
Yeah, and they're getting rated on a 5-star Yelp score.
Yeah.
I mean, this consumerist culture is doing tremendous damage. By the way, the guy who discovered antibiotics warned after he got the Nobel Prize in the 1940s about the overuse of antibiotics. And now with the resistant bugs to antibiotics, because we're prescribing so many, it threatens to undo a century of progress in making surgery safe and childbirth safe and treating these ear infections. So if it's a bacterial infection or highly suspected to be bacterial, an antibiotic should be started early. We don't want kids to have learning loss because they have hearing loss that's undiagnosed because someone blew off their ear infection. It is a balance. Same with childbirth. You don't want to have a total medically free childbirth in the woods by yourself without any access to a healthcare professional. That's dangerous. At the same time, we have been over-medicalizing ordinary life. So the pendulum has got to sit there in the middle, and it's nuanced.
Like bringing back VBACs, for example, the vaginal birth after C-sections, right?
Yes. So the idea that once a C-section, always a C-section was a medical dogma, unsupported by the literature. And sadly, many women have had C-sections they didn't need because of that dogma. I know OB doctors who have a VBAC rate. That is, if you had a prior C-section, they're able to do a vaginal delivery in about 80% of those women.
You haven't written about this in your book, but this is obviously your field. What do you think about colonoscopies? Because I'm hearing that, everybody is prescribed to go get a colonoscopy, but there's also a risk in getting it. So where do you fall on that?
Well, people can do a DNA stool sample test like the Cologuard test, and it's more frequent, has some more false positives. But colonoscopy is a reliable way to screen for colon cancer, but probably a sigmoidoscopy would be sufficient. There's never been a randomized controlled trial of sigmoidoscopy versus colonoscopy, and most of the cancers are in the sigmoid region or can be detected with a sigmoidoscopy. So we have a lot of dogma like you have to get a colonoscopy. Turns out a sigmoidoscopy is better supported in the literature, and in my opinion, sufficient. More people would have access to it because it's not as involved, and more people would be likely to agree to it. Therefore, we'd overall increase the health of a population if more people were good with the screening protocol.
What about stents?
So stents also were medical dogma that we opened the blood vessel, therefore you're going to live longer. Big trial finally got done called the Courage trial. 0 survival benefit to a heart stent unless you're having an acute coronary syndrome, in other words, an active heart attack. Now, we can improve the symptoms of angina or chest pain if someone has chronic angina, but the idea that you were going to live longer just because we opened it up ended up not being true. After a golden era, 15 years of entire hospitals and buildings and careers built off of putting stents, we called them stent jockeys. They made tons of money and they were promoted and elevated, and now they're kings of medicine. Many of the people at the New England Journal of Medicine were cardiologists and were observed this rise. At no point did anyone ask, hey, are we making people live longer?
What I would imagine that there's also a risk in getting a stent in your heart.
Everything has a risk. Everything has a risk. So now the indications have narrowed. The field has cleaned up. Cardiology has done a good job creating appropriateness criteria, policing what's going on. We have peer review of cases between hospitals in my state of Maryland. And so the field has cleaned up. But now we're seeing the new Wild West is putting stents in leg arteries, sometimes screening minority communities at churches saying, hey, we're going to take a look at your circulation, free health screening. And before you know it, you end up on an angiography table and you have a stent in the leg artery because you signed some form. And so this is the new Wild West, is putting in stents in what we call peripheral arteries right now. And by the way, if we know the nudge terms in medicine, you tell a woman anywhere in the world who's in labor, a C-section might be safer for the baby, 100% of women are going to say, do it now. You tell an older gentleman, in your knee that's bothering you, you have bone grinding on bone, so-called bone on bone. 100% are going to say, do a knee replacement. We have learned the nudge terms to kind of get people in the gray zones to do what we want them to do. And it's well known in the field. Now, great, we don't want to create cynicism. Most doctors are doing their best, but they are being pulled by these heavy financial incentives. And so that's why it's good to have a good rapport, trust, and believe in your physician.
Well, something I'm somewhat cynical about is insulin. All these kids are on insulin right now.
Yeah. Insulin is a one-hammer approach that we've seen taken by the medical establishment. And don't trust pharma to fix this problem. Just like big tech created the mental health crisis of kids impulsive, checking their phones, and they're in this study saying we're anxious from our phones. 44% of teens say the phones are making them anxious. Do we really think big tech is going to come in with a solution as they're promising? Is big pharma going to come in with a solution to the over-medicating problem? This is where we've got to take a step back and realize that we are working for the everyday American. We're not working for the industry or the machine or the man. The H in NIH is supposed to stand for health, and the F in FDA is supposed to stand for food. We've got to get back to the basics in healthcare.
What mark would you put next to insulin? Question mark? Are there markers that you would say, maybe I should double check with another doctor before I get on it?
Well, where's the discussion of food? Where's the discussion of the fact that bread is basically now sugar because of the way we process the flour? We strip it of the fiber. We chop it up. We strip it of nutrients. We add back a couple chemical nutrients and call it enriched flour, fooling people into thinking it's good for you now.
Yeah.
And some of these substances don't occur in nature. Okay, 10 to 20% of the calories of Americans today are from seed oil derivatives that are highly processed. They sound natural, like sunflower and soybean and corn, but these and canola oil. These are not naturally occurring derivatives. They're highly mechanically and chemically processed, denatured at high temperatures to sell them at low temperatures that can sit on the shelf for a long time. What's happening when it goes down the GI system? All of these things, microplastics, pesticides, the seed oil derivatives, the GI system has its own immune system embedded in the lining of the GI tract. And it's reacting. It's seeing foreign things, and it's reacting not with a giant inflammatory storm, but with a low-level inflammation. And it's creating general body inflammation, and it's making people feel blah.
Doctor, can we save our microbiome? And so if, let's say, you're a mother who had to give a C-section, or a mother who could not breastfeed, or a mother of a child who had to take a lot of antibiotics, are there ways to revive it and save it? Or is the new market for things that save your gut is just another marketing facade?
Well, there is a role for probiotics, and in infants, it's been found to reduce some downstream complications. The question is which ones, and that's where science hasn't really invested a lot of investigation. The probiotics that are most popular are the ones with the best marketing campaigns, but we're starting to understand a role, and sometimes people can try different things. The most important thing to protect your microbiome is eat organic foods, avoid unnecessary C-sections, avoid unnecessary antibiotics. And in Mount Sinai Hospital, they're actually taking vaginal fluid and swabbing it on the baby's skin when they have to do a C-section. And so the idea is that they're going to reintroduce and recolonize that natural process. And to answer your question about insulin, where's the conversation about lowering your insulin levels, lowering your glucose levels through food? You can cure 90% of non-type 1 diabetes by changing what people eat. And yet we never talk about it.
That is incredible.
We don't have to be medicating all these kids. If we can spend time with people and help them get the food that makes them healthy, we can actually cure 90% of non-type 1 diabetes.
Well, and speaking of helping kids, peanuts.
Yeah, peanut allergies. We have this modern-day peanut allergy epidemic in the United States. It's by and large a man-made epidemic. Peanut allergies existed in the past, but they were rare and mild. But in the year 2000, the American Academy of Pediatrics decided to tell parents to avoid all peanut butter and peanut products for kids 0 through 3 years of age, with the thought that peanut avoidance would reduce future peanut allergies. They got it perfectly backwards. They ignored a basic principle in immunology known as immune oral tolerance, or the DIRT theory. When you're around something the first couple of years of life, your immune system recognizes it and is less likely to react. So for 15 years, they marched on this train of a total peanut avoidance for young kids. Peanut allergy rates started to go up right in front of their eyes in the first few years. And you know what their response was? People are non-compliant. We have anti-science parents out there. We've got to double down and get more compliance. Total peanut abstinence.
They were the anti-science people, but really you should have lathered your baby in peanut butter. Or that Israeli bamba snack.
Bamba snack, any peanut-based foods that don't provide deliver a choking risk.
Right.
4 months, 5 months, 6 months, as soon as a baby can take oral intake, introduce a little peanut butter, milk, eggs.
Everything.
Be around cats and dogs. That's
what
the
about
pediatricians. Honey? So honey can present a choking risk, but same thing with honey, a safe amount of honey also. So
That's unbelievable. I mean, I'm just, okay, my oldest is 11, my youngest is 6. A minute ago, I was just told no peanuts, no peanut butter, no honey.
Peanut butter is still not included in the WIC program for infants, a modern-day scandal. The medical establishment got exposed 15 years into their dogma, just about 7.5 years ago, with a New England Journal study where a guy in the UK finally had the courage to challenge this deeply held assumption. And he did a beautiful randomized control trial with 640 kids, and he found peanut avoidance caused an 8-fold higher rate in peanut allergies. And this modern epidemic, which includes the new severe reactions, that is, kids can die just from being near a peanut.
Yeah, I have a few friends with kids who could die from that, which is why our schools don't allow peanuts in the schools.
That's right. It's become this self-licking ice cream cone. They've created this vicious cycle where they've created this intense immune sensitivity, and then the treatment has been more avoidance, which creates more.
It's punishment for the hubris of the medical field.
I tracked down some of these people that made the recommendation, and their answers were pathetic. They told me things like, well, we had to tell parents something. We had to tell them to do something. I said, no, you don't. No, you don't. If you don't know, the right answer in medicine often is, we don't know. And that's okay. Yeah. Another guy said we have to keep it consistent with a prior pamphlet that the American Academy of Pediatrics put out. We were trying to do consistency. And another person said, yeah, I could tell this was all bogus, but I was new on the committee. But we don't do well when a small group of people make decisions for the entire population on health, and they're not using scientific evidence. They're shooting with a gut feeling, and they're propagating medical dogma or misinformation.
Right. And when medicine and doctors are censored, nobody does well.
That's why we need civil discourse. We need to invite people who have different opinions to discuss it. Remember when Obama was asked what's his favorite book when he first ran for president? He said, Team of Rivals, because it's good to have different opinions.
If he only believed in that for real.
Well, I stay out of politics, but you may be right. I'll tell you that the guy who opposed the low-fat diet, he said, no, it's not fat. It's sugar. It's refined carbohydrates. Look at the ultra-processed diet. His name was John Yudkin. He was in the UK. Man, they crushed him. They crushed his career. They took his lab away. The guy who was the sort of Tony Fauci of his day, Ansel Keys, who promoted the low-fat diet.
Yeah.
They did a randomized controlled trial at his institution, and it failed to show the low-fat diet reduced heart disease. It went the other way. Low-fat people on the low-fat diet had a higher rate of fatal heart attacks. They suppressed the study for 16 years. When one of the guys was asked why, he said, we were just disappointed in the way the randomized trial turned out. That's not how science works. You've got to invite dissent. I do it on my research team. Show me guys where I'm wrong. I could be making a mistake here. We get tunnel vision. In medicine, we get myopic with our specialty approach. And we've got to invite fresh new ideas. We need big ideas. The NIH is funding these small incremental discoveries. You do this little discovery in this little tiny field, we're going to give you some money. What are we doing? I mean, the top paper in the cancer conference was a chemotherapy that's been around to a new type of cancer increases survival by a couple months with no added cure. That's the top scientific discovery in cancer for the year at our top paper with $300 billion investigated. We need big ideas. We need to challenge deeply held assumptions.
Okay, so doctor, I want to pack in a few more important nuggets here. So mammograms, what are your thoughts on mammograms?
There's actually never been a randomized controlled trial to support moving the age of screening mammograms from 50 to 40, which they just did. So it was a medical dogma. They said, we think there's benefit to starting earlier. They don't know. They are seeing more cases of breast cancer in younger people. That was the rationale. But it wasn't supported by a solid trial. There is a risk that we're giving people radiation with the mammogram. So I recommend sticking where the evidence supports it better, and that is starting at age 50 for low-risk women, not 40 as is currently recommended.
Wow. What do you think about breast implants? We're in Los Angeles, I have to ask.
We're in Silicon Valley, as we call it in surgery, and The breast implants do not cause autoimmune diseases,
Okay.
as was initially claimed, or this so-called chronic fatigue syndrome. There was a large study that evaluated this question for a court case, and the court case was basically thrown out because the evidence did not support it. Silicone implants were banned for many years with this concern, but to this day, almost 3% of adult women in the United States have an implant, and silicone is the implant of choice because of the softness and the feel. But the irony is the FDA took it off the market because they said we didn't have long-term data. At the same time, they approved OxyContin based on a 14-day study, and they approved it for chronic pain, igniting the opioid epidemic. And it does beg the question, could it be that many of our modern-day health crises have been created by or hastened by the hubris of the medical establishment, igniting the opioid epidemic, igniting the modern-day peanut allergy epidemic, igniting the obesity epidemic with processed food and demonizing natural fats. And some would argue creating the COVID-19 pandemic from scientists messing around with a bat coronavirus in a laboratory.
Nefarious or accidental?
I think it was accidental, but 2 years prior to the pandemic, they submitted a grant to the United States government that was the cookbook on how to make COVID-19. They said they would like to have funds in the grant to take a bat coronavirus from a remote part of the country and then insert a furin cleavage site to enable it to infect mammalian or human cells. That was the grant proposal the Wuhan lab submitted 2 years before COVID. So it's not a mystery. It's not the riddle of the Sphinx that the world epicenter was 5 miles from that same lab.
Do you have any thoughts about other vaccines? Like what about the flu shot, for example?
So we need a universal flu shot instead of this annual runaround. You come, we'll have nothing to do if we don't tell people to get the flu shot each year. Between people smoking less and the flu shot moving to a universal flu shot. But there's a new universal flu vaccine that unfortunately is sitting in phase 1 trials. There's no interest from the NIH, our government, or pharma to have a one-time universal flu shot that could last a lifetime. It would work against bird flu, as we've seen in animal studies. And I write about it in the book Blind Spots. We need to get that flu vaccine so we get away from this annual circus of trying to predict which strain is going to be dominant and then trying to target that strain each year and making people just feel terrible if they don't get a shot that, in young, healthy people, barely works. It may shave off a day or two of illness.
The medical establishment is going to have to do a lot of work to regain our trust after what has happened with the other vaccines. And so it'll be interesting to watch. I mean, you talk also about Tamiflu, which was another one of those things that has been pushed on us for a while, and people have kind of lost trust by seeing that it doesn't really work so well.
Part of the national security stockpile to have Tamiflu, it barely works. And we only found that after a deep investigation by a group of scientists that said, we want to see the raw data. We don't want to just take pharma's word for it. So imagine for other drugs, if we saw the actual raw data, what we call the clinical reports that say this person in the trial had this description of what they experienced. Imagine what else out there we would discover may not work.
Imagine informed consent. Imagine that. What do you think about Tylenol?
Tylenol is massively overused. If a kid or anyone has a fever, you don't have to treat it with Tylenol. It's the body's natural way of increasing temperature to try to rid itself of the pathogen. Now, if a kid is uncomfortable, we don't want kids to be uncomfortable, then it may make sense. But otherwise, it may just prolong.
What does uncomfortable mean? My child is uncomfortable sitting at dinner, okay? So, you can't use that as a litmus test for when to apply meds.
If a kid is visibly uncomfortable crying and it's obvious it's from the fever, inconsolable, and it's clear it's from the fever, then it's compassionate, I think, to use it. But a recent study found not only out of my institution, when it was used for chickenpox, it extended the illness, because you're getting rid of the body's natural regulatory way of increasing temperature to try to rid the pathogen. And another study out of Duke questioned the safety of Tylenol in very young, small children. And so that is a question that we have to look into. Is These are deeply held assumptions that Tylenol is entirely safe in children. It's worth us asking questions.
What are your thoughts on fluoride?
So we fluoridate most of the drinking water here, but in Europe it's 3%, and in Canada it's only a third of the drinking water. If fluoride is killing bacteria, which we know it does, in the mouth, reducing cavities, what is it doing to the bacteria in the microbiome? It may be doing damage and altering the microbiome. And a recent study in one of the JAMA journals found that the fluoride may be accumulating in one of the learning centers of the brain, which is why they saw lower IQs among children in fluoridated areas where the water had fluoride added.
So what about toothpaste?
So it's the current recommendation to avoid fluoride in toothpaste for young children. That's probably for a good reason. Maybe the kids should not be drinking sugary drinks and these juices with added sugar. Maybe there's another way, instead of adding a bactericidal agent to the drinking water, that we can address the cavity issue.
Well, doctor, I am so grateful for people like you. And I hope that people like you will continue to go and meet and have your conferences and speak freely and really battle those ideas so all of us can benefit from the sparks that come from those disagreements and the battles. And so bless you and thank you.
Thank you.
I will continue to follow your research because I personally want to get more educated.
Thank you, Marissa. Great to be with you.